bit just in case people argue. Right, so those who haven't answered first time, I'm going to go through it one last time. So if you hear your name, you answer. If you hear your name, or if you're not here, obviously you don't answer. Gad Malakhiyali.
I think she
You're not
typed in
here.
the chat earlier when you said her name.
All right, let me say it again. Gad Malakhiyali, are you here? Gad Malakhiyali, this is your chance to answer. You're not answering, so you're absent. Iman al-Yamahi. No. Khulud al-Ahbabi. No. Mira al-Khiyali. No. Salma al-Khiyali. No.
Dr.
Salma is here?
Salma is here.
Okay, all right. I think Mira Sina, no, not Mira Sina, Hur al-Shamsi. No. Shireen al-Shamsi. No. Sham al-Mansuri. No. Maryam al-Za'abi. No. Reem al-Kitbi and Fatma al-Amri. Okay. Right, anyone here haven't heard their name being called out?
Doctor,
Yes.
did you call Reem al-Zahri?
I don't know. Did I call Reem al-Dhari? I don't know. I called many people.
Okay.
I called 70 people, so I don't really remember. There's lots of Dhahiris, mashallah, but there's lots of Reems as well, so I don't know. Reem al-Kitbi is one that's missing, but I don't know if Reem al-Dhahiri is missing. Hang on.
Doctor?
Just wait a second. Khulud, Iman. Okay, who's now doctor?
Gad Malkhali.
Okay, fine, you're in. All right, that's it. We're done.
Yes.
All right, guys. Quick catch up. Last time, anyone remember what we covered in the last lesson? Just general kind of headings, just so that we can connect our minds to the last class. Anyone remember? Hissa, go for it.
We have covered how to define abnormality and normality, and we've discussed also how to classify mental illness, how they usually classify it by the books ICD-10, and I don't really remember the other one.
DSM, excellent. Well, you've done well remembering what you did remember, though. Well done, Hissa. Good. Who else has got their hand up? Ahmed, yeah, Ahmed al-Mansouri. Anything to add?
Yeah, we also added, we discussed how some illnesses are they are classified as purely biological in terms of hormones or abnormalities in the brain. Others classified as related to upbringing and in the environment that one lives in.
So we looked at different perspectives on mental illness. Correct. Yeah. Well done. Reem al-Dhahiri, you want to go? Add anything to?
We discussed anxiety and the difference between anxiety and panic attacks.
Okay. What kind of anxiety did we look at? Because remember, there was lots of anxieties. What kind of anxiety did we look at?
Actually, that specific detail I don't remember. I remember you mentioning panic attack or sudden. And,
yes. I did talk about panic disorder. Yeah, I did talk about panic disorder and anxiety. But well done. That's good. Reem Sumaiti.
Doctor, was it generalized anxiety disorder?
It was exactly that. Yeah, well done. Generalized anxiety disorder. Yeah, and panic disorder. Good. So that's where we left it. So today we're going to pick it up. We're going to. It looks like we're still going to need one more lesson next week. So the first lesson of next week, we're going to have a lesson. Half of that lesson we will, half of that lesson we will be doing what we leave from today, which will be personality disorders, if my timing is correct. And then the other half of that lesson will be for reviews, revision, whatever questions people have, issues, whatever. So next class, the first class of the week we will have on, and that will be our last class. Right, so moving on to today. Still looking at the anxiety disorders now. Remember, these anxiety disorders are within the sort of general field of neuroses, which are the less serious mental health problems. When we say less serious, we mean, people are still in touch with reality in a sense and know that they've got an issue. Whereas the more serious mental health problems are people where they kind of dissociate from reality and have their own reality, which doesn't really map onto the reality that the rest of us share. So we're still talking about neuroses now. And we're going to be talking about agoraphobia first of all. Anyone heard of agoraphobia before? No? No, don't write anything. If you don't, that's fine. If you do, just put your hand up. All right, Marwan, go for it.
Isn't it the opposite of claustrophobia, the fear of open space?
I was hoping someone would say that, Marwan, because that's the general myth. Yeah, that's what everybody who
That's
who's heard
what I
of
heard.
agoraphobia. Sorry.
That's what I heard of
Yeah,
agoraphobia.
unfortunately, that's the myth that's out there. People think that agoraphobia is fear of open spaces. It's not. You're not the only one. That's the general misconception. Agoraphobia is the fear of, I mean, the word comes from the Greek agora, which means marketplace. Basically, it's fear of crowds, fear of being stuck somewhere where you can't escape. Okay? So it's the fear of the marketplace, or actually it's fear of being stuck when in a place where you can't escape, right? So agoraphobia, in order to kind of be classified or diagnosed with agoraphobia, you need to have either a fear of or an avoidance of, okay? Well, let's say a fear in or avoidance of. So if you're in these situations, you feel really scared, or you avoid those situations in the first place. If you have fear in or avoidance of at least two of these situations on the blackboard, then we can start thinking about a possible diagnosis of agoraphobia. But like I've said before, I don't know if I've said to you guys, what we're reading, what we're studying these last 3 lectures, all you're getting is the tip of the iceberg in terms of diagnoses, which means you're just getting the very, very, very basic snapshot on how we diagnose these problems. But you cannot diagnose just because you've read these things. You can't go to your friends and say, oh, you've got agoraphobia, oh, you've got social phobia, oh, you've got generalized anxiety disorder. You can't do that because you're not qualified to do that. In order to make a diagnosis, you have to be a trained clinician. And many, many years of training to do that. Because when we're looking at a diagnosis, we don't just look at the symptomology. There's other things that we take into consideration, like a person's history, like comorbidities, like other biological problems, other medical problems. All of these things are taken into account when the diagnosis is made. So just to be aware, guys, what you're learning what you learned last week and what you'll learn first class of next week is for your information. It doesn't make you somebody who can make a diagnosis, okay? So be careful of that. It's unethical to pass on a diagnosis when you're not qualified to do so. Okay, so agoraphobia, fear in or avoidance of at least of these places here. So crowds, public places, marketplaces, shopping malls, cinemas, lecture halls, anywhere where there's other people there, especially crowds. Traveling alone, usually on public transport in my experience, and traveling away from home. The further away, the more the agoraphobia seems to be intense. So you have to be scared in those situations, or you avoid those situations in the first place in order to be diagnosed like agoraphobia. Now, as well as that, you have to have at least 2 symptoms. One, like before, the autonomic symptoms 1 to 4, as in the other anxiety disorders. You have to have at least one of the 1 to 4, the ones in bold, at least one of those, plus at least one of the rest of them, okay? So you have to have at least palpitations, racing heart, in other words, palpitating heart, sweating, trembling or shaking, dry mouth. So at least one of these, plus any one of the following ones that we have come across before. You know, difficult breathing, tightness in the chest, feeling dizzy, feeling faint, hot, feeling as if you're going to die, if you're going to pass out, all of those things, okay? Did anyone want to ask a question? No. All right, so that was agoraphobia. Remember, it's, yes, Shamma?
Doctor, don't you think most introverts have agoraphobia since they don't really like going out in public places and whatnot?
There's a difference between not liking to do something and actually having a panic attack when you are out. You with me, Shamma? So,
Yeah, I'm
you
with
know,
you, Doctor.
yeah. So, yeah, some people maybe don't like going out. It's not their cup of tea. But when we're talking about agoraphobia, we're talking about people who have an actual panic attack when they do go out.
Okay, thank you, Doctor.
All right, okay. Shahad, it's only you that can't hear me, so you have to sort your mic out or whatever your speakers. Yeah. Right, okay, so that was agoraphobia. Social phobia, anyone? What have you heard about social phobia? Anyone? Put your hand up. Sometimes called social anxiety. Young Mansouri, go ahead and tell us.
The fear of social situations, like speaking with people or dealing with people in general in social situations.
Yeah, pretty much, yeah, exactly. Let's go into a little bit more detail. So again, it's either a fear in those situations or an avoidance of those situations. All right, you have to have either or. Okay. Now, in situations where, obviously, because the word social, it means that it involves other people. And when you're in those situations, you worry, you have real fear that you might behave in a way that will be embarrassing or that you'll humiliate yourself in some way. That's your fear, that you're going to make a fool of yourself, you're going to embarrass yourself, people are going to think you're stupid, or people are going to think there's something wrong with you, right? And that makes you feel really anxious, okay? Now, in terms of the kind of situations you would avoid or be afraid in, different people have different manifestations of social phobia. When I work with people, there are different types of social phobias. Some people are okay talking on a one-to-one. As long as it's just one person talking to them, that's fine. They can deal with that. Some people can't stand that. They find that really tricky, but they're okay talking with, being in a group of people. Some people find a group of people really challenging, but one-to-one okay. Some people find people that they sort of know a little bit, like half know acquaintances, really challenging, but people who they don't know at all, okay. Some people are okay with people they don't that they know half, but are really anxious about people who they don't know at all. Okay, so there's different manifestations of it. The common thread that goes through the whole of the social phobia anxiety disorders is that you're afraid the fear involves another person. And it could include fear of eating in public or speaking in public, what we call performance anxiety, being in big groups, parties, gatherings, classrooms, anywhere really that involves other people. All right, like I say, in terms of number and type of other people, it depends from one person to the next. I don't know if I worked with this particular patient myself or a colleague worked with him. He was an actor in England, and he was brilliant acting, on stage. Not millions, obviously, hundreds of people could be watching him, he's fine. But when it came to talking, to people face to face, he found that very, very challenging. He had the social anxiety, but it was to do with just talking to one other person. But in performing in front of other people, he was totally fine with that. So yeah, it has many, many manifestations. Okay, so when you are in those situations, what you tend to do is you have to have at least 2 symptoms of anxiety. Same, at least one from the 1 to 4 that we spoke about before, those agoraphobia symptoms. Plus, you have to have at least one of these symptoms. And in my experience, blushing is a very common one. Blushing, when your face goes red, often people think that if their face goes red, and therefore they look anxious, and therefore people notice that they look anxious, so they worry that they are looking stupid, and that makes them more anxious, and then you've got a vicious circle going on. So fear of blushing is quite a common one in my experience. The other common symptom is shaking. People who have social anxiety, kind of one of the autonomic symptoms is kind of shaking, like, and like, carrying trays. Like I used to treat somebody, I took him to a cafe. One of biggest issues he had was when he pays the person behind the counter, he was worried that he will kind of either drop the money or not be able to put his, he would not be able to put the money in the person's hand, or when carrying the tray, he'll drop all the coffee, spill it all over the floor, because he had this kind of bit of shaking. All right, so that's social phobia. Questions? Now, with all the anxiety disorders, obviously one of the things that's important is that the fear, we all have a bit of fear sometimes, a bit of anxiety, like when meeting someone maybe, or when speaking in front of a group. We're talking about excessive fear here, right? We're not talking about the normal everyday fears that we all might have when we meet someone new or when we go and speak in front of other people. We're talking about a debilitating fear that actually has a huge impact on people's lives. Okay? Specific phobia. What about specific phobia? Sometimes they're called simple phobias, but they're by no means simple, but that's what they are referred to in the DSM, I think. But specific phobias, anyone know what they are? Heard about them? Heard of them? Okay, Ahmed, you keep your hand up. Keep your hand up, son. Let me just keep your hand up, and I want to see if anyone else wants to come in. Right, Ahmed, go ahead.
I wasn't sure about the answer, but I was gonna say maybe like fear of specific things, like fear of glass doors, or fear of maybe certain plants or colors or
animals or insects. Yeah, exactly. Yeah, that's it. So a specific phobia is a phobia of a specific situation or object. Okay, and here we have to exclude agoraphobia and social phobia, because remember, agoraphobia is also a fear of a certain situation, that is being away from home, being public places, being enclosed. in places where you can't escape and so on. Social phobia is being in situations where there are other people involved. So we have to exclude those two. Any other phobia of a specific situation or object is classified as specific phobia. Okay. Again, the criteria are marked fear in that situation, or because that situation is so frightening for you, you don't actually attempt it at all anyway. And some of the common phobias are phobias of insects, you know, spiders, cockroaches, things like that. Phobias. Some people have phobias of birds. People have phobias of certain animals, dogs, snakes, thunder. Some people have fear of flying. Some people have fear of small closed spaces, claustrophobia, otherwise known. Some people have fear of blood injury and needles. Yeah, that's it. You know, blood injury, needles, injections, dentists, hospitals, heights. Yeah, I have a fear of heights. Getting a bit better, but I still have it. So yeah, those kinds of things. People have come across people who've had fear of buttons. Yeah, fear of all sorts of things people can develop. Okay. So again, same in terms of anxiety symptoms, you have a panic attack in that situation, right? In a situation where you are afraid of that particular thing. If you find yourself in that situation, you literally have a panic attack and then you run away as far as you can, or don't go into it in the first place. Now, again, the important thing is that fear to be excessive and unreasonable. If you are in the middle of a jungle and you're afraid of lions, that's a reasonable thing because that saves your life. It's good to be afraid. Otherwise, you'd be mad not to be afraid. Yeah. If you are in a country where all the dogs are wild and stray and so on, to have fear of dogs, that's pretty reasonable. If you're in a country like England where dogs are all like, you know, tame and domesticated, then fear of dogs may not be reasonable because they're not frightening, they're not dangerous. So it's also to do with how excessive and reasonable the phobia is. And phobia is by definition an excessive and unreasonable, irrational fear. Okay, questions? No? Yes, Shamma.
Doctor, do you think people develop those kind of fears through traumatic events, or do you think they have it from before?
Okay, so remember when we talked about conditioning and learning and conditioning? Do you remember that?
Yes, doctor, I do.
Okay, so what happens in conditioning, classical conditioning? No? All right, if you are in a situation, right, you're a little kid, right, and then you don't, obviously as a little kid, you're kind of pretty open to things. You might be a little bit reluctant, but pretty open to things. But suddenly you turn the corner and there's a wild dog, like, really kind of barking mad at you. Obviously, you're going to shake and you're going to be frightened out of your skin and you're going to run away. That is one way you develop fear of dogs, is your personal experience of something that frightened you the first time you met it. That's what we call association or classical conditioning. You've been conditioned to associate fear with dogs. Okay, that's one way. Another way is you vicariously learn that. So you're a little kid, you don't know spiders, you don't care, you just see spiders as interesting, you might even go towards them, or cockroaches, you might go towards them. But then mum walks into the room and she freaks out, right, spider, or cockroach, and then you go, oh. And so you then learn the fear of spiders from your mother. It's called vicarious learning. So often phobias are learned experiences, either personal experiences or learned through other people. It can happen that you can develop a phobia as a result of a trauma. So if you've been driving and you had a horrible traffic accident, and that traffic accident has led to a trauma, so you've developed PTSD. That PTSD may be treated, but you might develop a phobia of driving afterwards. And I've treated people who have driving phobias as a result of trauma. Okay, so phobias don't necessarily have to have been developed as a result of trauma, but they can do. But they can be developed as a result of other learning experiences as well. You're right. You with me, Shamma?
I'm with you, doctor.
Answered your question?
It did. Thank you, doctor.
No worries. Okay, Yazan, yeah, I can't hear you, Yazan, to be honest. Don't know if you're talking, but I can't hear you. Maybe leave and come back because I can't hear you. Okay, next condition, OCD. Anybody heard of OCD? Obsessive compulsive disorder. Alia. All right, let's hear from you. What have you heard about OCD? obsessive compulsive disorder.
I have example. It's like the one who wash his hands over and over, and make sure the door is closed. It's about things a lot of something.
Okay, yeah. So they think something, either like they close the door because they think that somebody's going to come into the house and steal something, or they clean because they think there are germs on the surface. Yeah.
Yes.
Yeah. Yeah. Okay. Yeah. Generally speaking, that's signs of OCD. But let's have a look in kind of technical detail then. So OCD is made up of two words: obsessive compulsive, and in disorder. Disorder just means something's gone wrong. Obsessive.
Doctor, can you hear me?
Obsessions. Yeah, I can. Oh, Yazan. Yeah.
Oh, sorry for interrupting, but can I ask a question?
Yeah, go on in.
Are phobias limited to only experiences based off of reality? Like, for example, could you develop a phobia, like maybe through dreams, through something like consisting in your mind? Like, you don't have to experience the trauma.
And so, is the object of your phobia a real object or imagined object?
No, it couldn't be like, for example, I once had a dream like that I was swimming with a whale, but now I'm afraid of whales. But I've never actually even seen a whale in real life, but I still am afraid of them. So
yeah, but the object of your fear is a real thing. It's a whale, right?
Yeah, it's a real thing. Yes.
Yeah, that's fine. Yeah, you could develop it that way. Yeah, I thought you meant you have an imagined something, and that imagined something you're afraid of, like an alien.
No.
Okay, yeah, that could happen, and it obviously has happened in your case, so it definitely can happen because you've experienced it yourself. Yeah, it's not often. I don't come across it often, but what we do notice is that there are certain things that are more likely to be the object of phobia than other things. So we know that like snakes, dogs, like especially in this part of the world, not in England so much, snakes, spiders tend to be more objects of phobia than say fluffy rabbits or cute puppies or kittens. Because we are naturally predisposed to being alert to dangerous animals, so we're more likely to develop fears of those things, poisonous snakes, poisonous spiders and things like that. But yeah, it can happen if you've had a traumatic dream and that's made you develop fear. I was thinking myself where if I can think of other examples. No, I can't. But yeah, there you go. Yes, and that's you're an example of that.
Yeah. So it's more so if the object is if it's real. Then
it has to be real. Otherwise you wouldn't be avoiding it if it's not real. Unless I don't know. I've never come across maybe in our part of the world you have fear of jinn. I don't know, maybe you have a jinn phobia in this part of the world, but then what you might avoid is certain places where you think jinn are, like, I don't know, like derelict buildings or toilets and things like that. I've never come across that myself, but I can imagine some people might have that kind of phobia, yeah. All right, okay, so OCD, we said OCD is made up of two words, obsessions and compulsion, obsessive compulsive. The obsessive part is the thoughts. The compulsion part is the action. So somebody who has a cleaning OCD, their obsessions, which are the first things that compel them to do the action, their obsession or their thoughts, so change the word obsessions for thoughts, exactly the same in this sense. Their obsessions is, oh my God, that surface is dirty, and if I don't clean it, I'm going to catch COVID. So that's the thought. Oh my God, that's dirty, and if I don't clean it, I'm going to harm myself. The action is go and get a sterilizing spray and clean. That's the compulsion, all right? In terms of the checking OCD, like somebody who keeps checking cookers are turned off, they might have, oh my God, have I left the cooker on? If I did, then the gas might escape and there'll be a fire in the house. That's the obsession. Compulsion, go to the cooker and make sure it's closed. Okay, so OCD is made up of obsessions and compulsions. And sometimes you have obsessions only OCD. Sometimes you have compulsions OCD. Often you have both of them. Okay, so those that's important to understand the difference in obsessions and compulsions. Is that clear, guys? Right, okay. All right, I'm going to show you a little video of a person who has OCD, but obviously her Identity has been protected because it's now a cartoon, okay? So I'd like you to watch this cartoon of this person who has OCD. It's a typical kind of case, and this person has multiple types of OCD at the same time. She has ordering OCD, she has checking OCD, yeah, cleaning. I'm not sure if she has cleaning, but checking and ordering OCD. So have a look at this and stop at minute 3 and come back when you've watched it, okay? Try and think what her obsessions are and what her compulsions are. Okay, try and differentiate between obsessions and compulsions. Think about, write a list of her obsessions and a list of her compulsions. Okay, I'll see you back in 3 minutes. Right, okay, so most of you should be finished by now. Okay, let's come back. So guys, just to be clear that I'm not going through every single slide because I'm trying to cover as much ground as I can, but every single slide is important and you have to know it for your final exam, yeah? So that just because I haven't covered it doesn't mean may not be in the exam. It may well be, okay? But I'm just giving you the general outline so that you're aware and so that you have a kind of a basic understanding, but the details in the slides. Right, finally, depression. Yes, Iman Farsi.
Doctor, how does a person develop the OCD disorder?
How does a person develop OCD?
Yeah.
It's not really that clear. Some people have a genetic predisposition. Some people, in my experience, also people who have been given too much responsibility when they were kids. So people who have had to be a parent to their parents, if you like. They've been before they're actually mature enough to do that. So they take on the sense of responsibility quite early on, and they become always kind of have a sense of responsibility for everything. And then later on, obviously, the likelihood that they have to make sure everything is closed or everything is turned off becomes exacerbated, especially if there's a horrible life event that they go through. Yeah. So in my experience, there's a genetic element, but there also is the issue, I think, of people who have been given too much responsibility when they were children. Yeah, is that all right? Okay. So depression. We all have heard of depression. It's a mood disorder, and there are 2 general classes of mood disorders. I'm going to talk very briefly about depression now, and then talk about bipolar disorder in the next set of slides. Now, the depression, even though it can be really horrible, people who've experienced depression know what it's like, debilitating, lacking energy. People feel really down and out to the point where sometimes people want to take their own lives. So it's not simple, but it's not as serious as bipolar or other forms of psychotic depression. So we're going to be talking about what we call major depressive disorder, which is a kind of depression that people experience from time to time, quite common these days. Well, I don't know if it was common before, but certainly a common experience. Lots of people will have depression at some point in their lives, okay? Just like the other anxiety disorders we spoke about. Now, it's also important to differentiate between something we call reactive depression and something we call major depressive disorder. Reactive depression is when people feel down, feel low as a result of a life event that would make anybody feel down and low. So for example, if you lost a father or a mother or a grandparent who you were close to, or a brother or a sister, they died, God forbid, you would feel sad. And if you didn't, then there would be something wrong with you, if you like. It's normal to feel sad. So that's not the depression we're talking about. And if you feel sad, you might not want to eat like you used to eat, might want to sleep too much, can't sleep. You might don't want to do stuff, you don't want to see people. That's all normal if you've had that experience. Or if you had a relationship and you broke up with your wife or husband, and it was a long, loving relationship, and now that you're divorced, that could make you feel down, right? Or if you lost a job that your livelihood depends on, that could make you feel down. So these things are reactive depression, and that's not what we're talking about. What we're talking about, and those things are normal. The feeling of sadness as a result of those experiences is normal. What we're talking about is when that period has gone, but you're still feeling down, or you're feeling down for no particular reason. That's when we might think about depression. Okay, and depression can be classified in terms of symptomology into the following symptoms. So you have to have at least 2 of these 3 symptoms here. 1, depressed mood, which basically means you're feeling down, you're feeling low in mood. Anhedonia, which basically means you have lost pleasure in doing things. You don't have the pleasure in life that you used to have. You don't enjoy reading books when you used to enjoy. You don't enjoy going cinema when you used to enjoy it. Life has lost its taste, if you like, okay? Anhedonia. And the other symptom is energy loss, so feeling lethargic, feeling lacking in energy. So you have to have at least 2 of these in order to be diagnosed with depression. And you have to have had these symptoms for at least the last 2 weeks. And like I say, you have to have had it in the absence of any major life event, okay? And then you have to have at least 4 of the other symptoms, 4 of the following 6, okay? So reduced concentration, so you can't concentrate like you used to, or you'll get easily distracted. Reduced self-esteem, you think you're not good enough, or you've let yourself or other people down. Feeling guilty that you might have done something, or you're feeling worthless. Feeling hopeless about the future, that the future's bleak. There's nothing to look forward to. Nothing good is going to happen in the future. I'm going to stay like this forever. Things are gloomy. Sometimes you might have ideas of harming yourself or taking your life. Disturbed sleep. Sometimes you might sleep too much. Sometimes you might not sleep enough. Sometimes you sleep, but you don't get refreshed as a result of your sleep. So that's what we mean by disturbed sleep. Diminished appetite or increase in appetite. Diminished means you lose your appetite, or you eat too much as a way of comforting yourself. So any 4 of those symptoms would suggest, plus the presence of 2 of the ones in bold, will suggest the possibility of depression. All right, leave it there for that one. Any questions? Okay, Shamma al-Mansouri?
Sir, does it have to be after an event?
No, I just said it mustn't be after an event. I said it mustn't be.
Oh, okay,
If it
sorry.
was after an event, yeah, if it was after an event, then it would be reactive depression. If it wasn't after an event, but the event was such a long time ago that other people normally would have moved on, then that would also constitute depression, yeah? But not immediately after an event. So like if you've dad, God forbid, just passed away and you feel sad, that's fine. But if it's been 6 months since he passed and you're still feeling the same way, then that may be a problem, yeah?
Yeah, okay. Thank you, sir.
All right. Right, moving on to the more serious now, mental health problems. And I'm going to talk about 3 types, well, 2 types today and 1 next time. Bipolar disorder, which is, I'll ask you, have you heard of bipolar disorder? Sometimes called manic depression. Okay, well, maybe you can share with me what that is. Who wants to share with me what manic disorder is? Shamma, you got your hand up again. Ariam, go for it. Ariam.
What time?
Yeah.
I'm talking.
Sorry?
Okay.
Yeah.
Can you hear me?
I can now, yeah.
Okay. So it's like one time you're over the roof and so happy and enjoying things, but then like a minute later you feel down and you feel sad and you can't enjoy things anymore like you used to, like a second ago. So these mood shifts and mood swings are what causing. Like, I hope you understand what I'm trying to say, but yeah.
Yeah. I think, I get what you're saying. Yeah, and that's what most people think. The mood swings where people go have extreme mania, high of, climbing the walls so high, out of control high, and then periods of low. Now, most people think that happens, like I say, 1 minute to the next. And that's not what bipolar is. And that's why I want to say, because people I notice in this country think they have bipolar disorder, and all they have is mood swings, basically. Bipolar disorder is a different kettle of fish. Bipolar disorder is something that is very serious. Some people can start to hear voices, see things.
Sorry, can I just correct this one thing? Actually, what I experience is it's like, for example, 2 weeks, I'm just happy and I feel like I deserve everything. But then the next 2 weeks, I feel like that I'm worthless and stuff. So that's
okay, so maybe period of time, yeah. So not within 1 minute and the next, yeah. That's more like it. But I don't know if you have bipolar, given that I don't know. Obviously, I don't know you. And let's have a look at what the official classifications are. There are different types of bipolar disorder. Bipolar 1, which is the more heavy one, where people do have, like when we're saying highs, we don't mean just like feeling high. We're talking about people going overboard, doing really risky behavior, spending loads of money that they don't have, or taking really, really massive risks on things. And they feel out of control. It's not like a happiness where you feel great and you can do so. It's like your head is spinning out of control, and you're like, it's like driving, I was like it, driving a car, a sports car really fast, and you don't have any brakes. Okay, so that's what it feels like. And the lows are crushing lows where you feel down, you're in bed, you can't even get out, like a proper depressive episode. And they can last. You know, well, we'll look at it in a minute, actually, instead of me like preempting. So why don't we watch this video to minute 3:45? Watch it to minute 3:45. Note down the different symptoms for the different types of bipolar. There's 3 different types of bipolar he'll talk about. Bipolar 1, bipolar 2, and cyclomania. Note those symptoms down. And then when you come back, I'm going to ask you about them. So see you back in a minute. Thanks, Abdullah. Right, some of you have finished. Sarah, Hissa, Salma, Abdullah. Okay, but there's still a few more. So those guys who've finished, can you look at this slide here and tell me where the spelling error is? There's a spelling error. Where is it on this slide? Hissa, yeah.
The cycle one.
What is it? What's it supposed to say?
Cyclothemia.
Yeah, exactly. Well done. Yeah, it's supposed to be cyclothymia, not cyclomania. Cyclothymia. Thymia is the depression part. The cycles of depression. Cyclomania is the mania part. So it's supposed to that I need to change that. Just noticed it. So cyclothymia on that one. Right. So you guys had a look at that. Any questions? I'm not going to go through it because of time. As I say, I need to just cover schizophrenia very quickly before we close today. Any questions about that? No. All right. Moving on to schizophrenia. Anyone heard of schizophrenia? Hissa al-Karbi. Okay. What have you heard about schizophrenia then, Hissa?
So from my idea of what schizophrenia is, it's basically the patients or the casualty with schizophrenia, they interpret real life or the reality in a very different way, in which it's really full of like hallucinations and delusions that they think that it is their reality. So when someone with schizophrenia tells you that they see something or they hear something, for us it will be like, you know, you can let it go and, you know, push it away, but for them it's really their reality.
Yep. That's good. Yeah, so people with schizophrenia, you know, they in our everyday language they call it infisam al-shakhsiyya, as if, and what they mean in everyday language is as if that people have different personalities. That's not what it means. It doesn't mean that people have different personalities, because there is a type of disorder called identity disorder, multiple personality disorder, which is where people have literally different personalities. Here, a part of the person's brain is split off and it has its own existence, and the person doesn't acknowledge that as being part of them. They see that as being someone else. So they can hear voices and they don't think those voices belong to them. They think those voices are other people's voices, actual other people. Or they might see images and they think those images are real. They're not images that they were created by their own mind. Okay, so let's go quickly through the diagnostic criteria or characteristics, let's say, of schizophrenia. And so a person with schizophrenic will probably have most of these symptoms to be diagnosed with schizophrenia. Now, there are different types of schizophrenia. We're not going to go into that. We're just going to look at the general overall arching diagnosis of the problem. So delusion are a technical word for false beliefs. Beliefs that are fixed in a person, but they're not true. And these can include beliefs of paranoia. So lots of people with schizophrenia might think that other people are watching them, like seriously watching them, like there's like monitors all over the place that are watching them all the time, and people are recording what they do, and they really believe that to be the case, or that they are being observed by aliens, or they've been watched by the secret services, so all the time. And it's, for them, it's not just, I think that person thinking, no, it's actually knowing in their mind that that person is looking at. The other types of fixed beliefs is delusions of grandeur, where people might believe themselves to be other than who they are. And often, in my experience, and I suppose clinically that's what comes up, people believe that they are some sort of a major world figure or a major historic figure. In England, some people come and say they believe they're Jesus Christ sent to humanity again, or they are some sort of prophet, or like I saw a video on YouTube about a guy who thought he was the Mahdi. So delusions of grandeur means they believe themselves to be grandeur, to be some major world figures, right? Hallucinations, that's when there are disturbances in perception, so they don't actually see reality as we see it. They could be auditory, where they hear voices that other people don't hear, or they may see images. And the voices are more common than the images, although I've worked with a client who had images. He was kind of from an aristocratic background, and he had images of some of his relatives always kind of being there. Now, the thing about these voices and images are often very, very critical. They're often like criticizing the person or demeaning the person or degrading the person. And that's why they're distressing. You hardly ever have these voices where the person is being encouraged or being praised. It doesn't work that way. In schizophrenia, these voices are often very derogatory. Disorganized thought, as well as those things, they'll have disorganized thought. It means their kind of thought goes all over the place. And that's sometimes expressed in what we call word salad, which is they say things that are actual words but don't make grammatical sense. Words are put together in a really strange way. Incoherent speech, basically. The table, the cat's car. And it's like, it doesn't make sense to everyday person, but that's kind of a sign of how random their disorganized thought is. As well as disorganized thought, they'll have disorganized behavior as well. Hang on, Ahmed, just one second. As well as disorganized thought, they'll have disorganized behavior, which means that their everyday life is out of control, very messy, very chaotic. Their house or their home will be messy. They will not be up to date with their rent or with their bills. Often in England, people who are like this end up on the street because they can't keep up with the demands of modern life, and they end up on the street if they don't get treatment. Yeah, they often self-neglect. They don't look after themselves. They kind of don't wash. They might weed themselves, not clean themselves, and leave themselves pretty badly kept. As well as those symptoms, which we would maybe in kind of clinical jargon sometimes call them positive symptoms. Doesn't mean positive, it doesn't mean they're good. Positive means they're things you can observe. There are also negative symptoms of schizophrenia, which are the schizophrenic person sometimes, often actually, would have lack motivation to do anything, so they'd be sitting in the house doing nothing all day. As far as you're concerned, they're doing nothing, but often they're kind of just responding to the voices that are going on in their head. They're too preoccupied with what's going on in their head. Sometimes they withdraw from other people. They sometimes in catatonia, for example, where people would literally sit down for hours and hours and not move a muscle, like a statue, completely still for that amount of time. Yes, Ahmed.
I was wondering if there are any historical figures or cult leaders who might have been schizophrenic.
I doubt schizophrenic. I doubt. The reason why is because if you're schizophrenic, I've worked with schizophrenics, you are pretty messed up in the sense that you can't even organize your own life, let alone lead other people. But there are cult leaders who are narcissistic or psychopathic, yes, because you are very manipulative and very charismatic when you have those kind of characters. So I doubt people with schizophrenia could lead any. They can't even lead their own lives, let alone lead other people. Yeah, Ahmed?
Yeah, that's clear.
Okay. All right, guys, that is it. And we'll leave personality disorders for next class. Okay. So there's actually, if you want to watch this, there's an interview with a schizophrenic. In England, this was done. Well, a role play of a schizophrenic patient being interviewed by their psychiatrist. This person was referred by their GP, general practitioner. Have a listen to it and see if you can work out the different symptoms that this person is displaying. You know, what are his hallucinations? What are his delusions? Yeah, try and see if you can work it out. I'm going to leave it there myself because I've got another class in a minute. But if you have any questions quickly, you can ask me now. Yes, Shemma.
Sir, it's not a question. But when you were taking the attendance, I was having a problem with the connection, so you didn't take my attendance.
Oh well, what can I do for you then, Shemma? That's it. It's done.
All right. Thank you, sir.
I've already put you in. Don't worry. I'm just teasing you.
Okay, thank you.
Last class. Yes, Sarah Bourawi.
I'm sorry. I wanted to ask this earlier, but I thought I'd waste time. So can I ask it now?
No, listen. Yeah, of course you can ask it now, but never think you're going to waste time, Sarah. If you have a question, ask. You never waste time. You always have good things to say. Go on.
All right.
Anyway.
About the the specific phobias.
Yeah.
I was a bit confused at that part because specific phobias were for like specific objects, right? And then
or situations. Yeah.
Oh, okay. And situations. So why not?
Yeah.
Why is agoraphobia not a part of that? Because it's also a situation.
Yeah. Except agoraphobia and social phobia, everything else.
So
If
why
there's a
are those
specific,
two excluded?
because normally with specific phobias, it's slightly simpler to treat, and there's not much, there's not more going on than just the problem. With agoraphobia, there's a lot more going on for the person than
Okay.
just the
So
fear of going out.
all
So
right.
so yeah, that's why that it's classified as a different disorder.
Like a lot more going on in terms of there's more like anxiety to do with it.
There's more anxiety and there's more history, normally complicated with depression,
All
because the
right.
person isn't going out doing stuff, so they end up staying at home all the time. Because they're staying at home, they're not doing the things they used to enjoy doing, they're not working, and that complicates things.
Okay, that makes sense. Thank you.
All right, okay, cool. All right, too many questions going on. I need my coffee, guys. Anyway, yalla, quickly, Ariam.
Doctor, I had a genetics lab quiz, so I wasn't able to